So welcome everybody to this ESOT webinar on COVID-19. Thanks a lot for taking the time. This is very timely, of course, and there are interesting developments as we speak every moment. So we'll try to give you a roundup of what's happening through the world. I'm only give you, my name is Luca Segantini, I'm the ESOT CEO. I'm only going to give you 1 minute of housekeeping rules. So all attendees are mute at the moment. So to keep the webinar manageable, because there's several hundreds of people on the line at the moment. The microphone will be unmuted during the Q&A session, but you'll see instructions later on in the presentation. You'll have to raise your hand, and then I will one by one unmute microphones of people who are willing to make a question. Or you can also type the question in the chat window in your dashboard. It's very easy to do. We have our two chairs, one from the UK and the other one from Rome. So I'm not going to take any more time, and I'm going to introduce Irene Bellini and Francesco Giovinazzo, and over to you.
Thank you, Luca, and thank you all for finding timing for joining us today with these webinars, and thanks also to Chiesi for its support with an unrestricted grant for this webinar. My name is Maria-Irene Bellini. I'm a renal transplant surgeon at Belfast City Hospital in the UK, and I am also the coordinator for Transplant Live, the ESOT e-learning platform. We must in fact recognize that learning never stops, and in a rapidly evolving field as transplantation, it is paramount to stay up to date with the latest innovation in transplantation. Therefore, we have built these discussion boards that I warmly invite you to visit on Transplant Live. And one of these is the one on COVID-19, in which we host a discussion between healthcare professionals, and in which we will share also this webinar at the end. So you are warmly invited to register. You can share, interact, and collaborate beyond your institution reach, as we are doing, in fact, like now. I now leave the floor to my co-chair, Francesco Giovinazzo, that is a liver transplant surgeon from Policlinico Gemelli in Rome, Italy.
Thank you, Irene. Thank you, Luca, and thank you all the speakers to come tonight at this time from everywhere around the world, listen about the COVID-19 situation and how we would like to manage solid organ transplantation. As you can see from the program, there will be two main topics. And we think that we want to have a very practical approach. And practical approach means that we want to know what's going on in different countries around the world, but we want to also investigate how you are distributing the resources between COVID-19 and solid organ transplantation. And briefly, I will mention about a survey that is going on. I think that many of you have listened or come across with the survey. Could we have the first slide, please? The survey is an international web-based survey where we want to investigate mainly the resource distribution in solid organ transplantation and the equity of those distribution. Next slide, please. So who should answer to this survey? We have thought that transplant surgeons are important, but we want to have opinion from intensivist and critical care doctor, and above all from people like ethicist, nurse, and coordinator that can give us a balanced judgment in the decision making. And what we have done is contact people in a multi-level and balanced way through Scopus, which is a scientific approach, through transplant scientific societies, social networks, and personal contacts. At the end of this webinar, we will give you some provisional results. I will invite you, if you have not already done, to join the surgery. But I don't want to take time from our speakers, and I would like to introduce our first speaker, who is Professor Umberto Cillo, the chief of the Hepatobiliary Surgery and Liver Transplant Unit in Padova University. Professor Cillo will speak about Italy outbreak of COVID-19 and risk mitigation in transplant candidate. Thank you, Professor Cillo. Thank you, everybody.
Thanks a lot, Francesco. Thanks, Irene. Thanks to ESOT organization for this opportunity to share ideas and pieces of information among Europe and worldwide. If I can have next slides, I don't have any disclosure to declare so far. Next slide. Yeah, clearly, I will talk about the Italian case. The Italian situation is pretty much a dramatic one. You are well aware about that. We are now seeing about 124,000 tested positive patients so far. And the death proportion is absolutely relevant, is 12.3%, as you can see here, even though we can see a sort of plateau in the next couple of weeks, probably a forecast that infectiologists are giving us. Still, next slide, this is a relevant figures, probably the worst mortality all over the world. Now, to better understand which is the relevance of what is happening in Italy, I think that this Imperial College study is very informative. These guys are epidemiologists with a Bayesian statistic. They were able to estimate the real amount of infected patients in Italy. The figure are about 6 million people infected so far in Italy, about 10% of the overall population, and this is pretty much similar in other situations in Europe. In Spain, they're estimated 15% of the population, which is a huge amount of patients. They also estimated that without mitigation measures, the amount of death toll would be something about 50,000 of death without mitigation measures. So we were able to save probably 38,000 lives if this projection is correct. Next slide, please. So we are just seeing the tip of the iceberg, and also it's very complex to understand which are the best mitigation measures that we can take into place. This is just a sort of comparison between two regions in Italy, which are very similar from the point of view of population, of healthcare systems and kind of management, even though completely autonomous. You can see that in Lombardy, which has been the amount of infected cases has been overwhelming, absolutely overwhelming. 50,000 people have been infected and tested positive, if compared to 10,000. Next slide. Well, even though the comparison is not doable, because clearly the amount of infected patients is different between the two realities, still, according to observers, and this is an Harvard Business Review, there is something that has been done in Veneto that can be useful for other realities all over Europe and beyond. That may be useful because in Veneto region, if compared clearly social distance, PPE, and increased ICU beds and ventilators, usual stuff had been tried to face. But most importantly, all health professional has been tested. I got 4 swabs so far, just to give you an idea. And this is because in Lombardy it was observed that the major source of infection were the hospital indeed. Then after that, and we lost a huge amount of lives, probably 100 100 professionals died during this crisis in Italy, which is a huge amount of deaths, clearly. And then we changed the approach in Veneto, trying to put the battle into the territory instead into the hospital. And now the people have been delivered experimental drug at home in order to reduce the amount of people getting to the hospital, in order to reduce a wave of overwhelming need of response that has been faced in Lombardy. And I hope that this may be useful for you. So huge amount of swabs, testing massively asymptomatic patients, because we have been showing that 70%, 65 to 70% of positive tests are completely asymptomatic and they can spread the disease. Next slide. So this is just a general idea. Going to transplant very quickly, clearly in Italy we have seen a drop in possibility to transplant from a mean of 75 transplantation for a week, every week. We went down to 45, losing 20 to 40% of the overall activity, transplantation activity. Next slide. And when we stratify the drop according to organs, you can see how kidney probably paid an important price, because probably we shut down the living donor donation, the living donor kidney donation programs. And in particular, also heart transplantation were pretty close to zero. Next slide. And as well as lung, as you can see, probably less than one lung transplant per week, if compared to 3 lung transplant per week in Italy, previous the outbreak in February 24, and transplant programs have been shut now. Next slide. Now a couple of words about what the transplant authority recommendation have been put in place so far. Just the red line to be more simple and more fast. Since March 30, it is mandatory in Italy that all deceased donor got a BAL through the analysis instead of a classical nasopharyngeal swab, because we are trusting much more in terms of accuracy to the BAL, and so we don't have any more suitability for transplantation for donors that do not have BAL. As far as recipient recommendation, the National Center for Transplantation suggests to get a nasopharyngeal swab to everybody, basically, even though asymptomatic recipients may receive it or not according to a doctor decision. Next slide. But let me go a little bit more into the details of what is happening in real life in most Italian centers according to adoption measure adopted in real life. So no living donor kidney transplant is anymore been done in Italy so far. No pancreas. Every pancreas program has been shut down so far. Cadaveric kidney transplant are still on place and active, but probably only in those institutions where the stress by COVID-19 is less important and people and professionals are less engaged. Life-saving transplant are all open throughout Italy, but with a higher degree of selection of candidates, as you can understand. We now in most centers are going to swap and get a CT scan to all the recipients immediately before transplantation in order to increase our capability to find the potentially positive developing positive COVID-19 patients. Of course, all transplant centers in Italy created dedicated free pathway, COVID-free pathways, with particular reference to operating rooms, ICU wards, and outpatient clinic. But, however, what we are pushing a lot to, and in part we already had a platform in order to implement telemedicine, because in Italy there is a huge amount of movement of patients from south to north and vice versa, and telemedicine is fundamental now to follow our transplant patient. We don't send anymore our equips abroad to procure organs, and send organs is basically mandatory so far because clearly of limitation movements, and just because Lombardy hospital has been so dangerous in terms of spread of the disease. About immunosuppression, it is very variable. Some suggest that the immunosuppression should be reduced in order to promote adaptive response, but with low prevalence of CNI in order to maintain antiviral activity. Any modulations, maybe corticosteroids, we will have time to talk about that. How about living donation in Italy? Probably more than half of the program have been shut down. Next slide so far. Just not to put in jeopardy the living donors clearly for potential COVID. Last two slides very quickly, just to give you some solid data. This data from National Transplant Center, the previous one, please, showing how many solid organs recipients have been infected in Italy. 153 out of 4,500 solid organ transplant live patients. Means 0.37%. Next slides. Mainly kidney transplant recipients have been infected, with 18 cases died. So the death prevalence in this particular population is about 15%, which means that is double of the same age-matched general population. It is at least in the Italian subset of patients. And these are very solid data because are cross data between Protezione Civile and National Center for Transplantation. Last slide, next one, is the one referring to waiting list prevalence.
We have 2 minutes off.
I'm done. This is the last one. 88 patients out of 8,000 waiting list patients got a COVID-19 while waiting an organ, and 8 died. 9%, 1% prevalence among the overall population of waiting list patients. I will stop here. I have a slide on next one on interference between the experimental drugs and immunosuppressant, but it can stay for the podcast analysis. Thank you. Thank you for the attention.
So thank you very much, Professor Cillo, for the wonderful presentation. I have just a very, very short question. So how much selectively we should be with transplant candidates? And I'm thinking the one, for example, that they are at that risk of dropout for cancer, like in HCC. What do you propose as a policy?
Well, I have relatively clear ideas about that. We have been studying the issue. We need to select patients that are in need, strong need for transplantation, no alternatives, high risk of dropout or death while waiting on one side. On the other side, patients that have good potential of recovery post-transplantation. So we should not select, for example, in liver setting, in my opinion, fulminant hepatic failure, acute on chronic failure, and retransplantation, severe transplantation, because this patient may engage ICUs and reduce the expected outcome long-term. So the benefit, the amount of lives saved with the so scarce resource that we have available so far is going to be reduced. So good performance post-transplantation in the early and post-transplant period, and very high need of transplant. Basically, the concept of benefit.
Thank you very much, Professor Cillo, and I will give to Irene.
Yes. Thank you, Professor Cillo. Very good insight into the Italian situation. I would please recommend our general speaker to keep on time. So now is for Professor Silvio Nadalin, an HPB and liver transplant surgeon from Tübingen, Germany, who will give an insight about Germany with a very high ratio of recovery died for COVID-19. So what is the ideal screening for the recipient candidate? Thanks.
Can you hear me?
Yes. Yes.
Can you hear me now?
Yes, we can.
Can we start?
Yes.
Okay. So, hello to everybody. Silvio Nadalin from Germany. I have been asked to talk about the management of transplant program in the pandemic situation, COVID in Germany. So we can go to the next slide. Somewhat.
Is this a slide you want? The one with the dashboard?
Yes, sorry, I was not. It's fantastic. It's okay. So this is the slide which depicts the situation actually in Germany. On the diagram on the below right, you see we are reaching the plateau. We are getting almost 100,000 positive infected people. If you check the numbers above with the marked with the red sign, we have almost 95,000 at the moment. This morning, 95,000 and 1,133 dead cases. Does it mean this means almost 1.5 mortality rate? in Germany. And if you go look to the chart of geographical card of Germany, you see the most dangerous or the high risk area are Bayern, Baden-Württemberg, where I do work, and North Rhine-Westphalia. So I've been asked to try to explain why the mortality is so low in comparison to other countries. For example, Italy, as Professor Cilo said. If we can just skip to the next one slide. So what I can say at this now, also also what the director of the Robert Koch Institute said. So first of all, in Germany, we test only symptomatic people. So the data we have, there are no true epidemiological data, because we don't know how many people have been in contact and how many are positive, are really negative, and so on. So we know only true positive symptomatic people. Why we have low mortality rates? Because probably we have performed many tests, more than any other countries, mainly in young people. Therefore, we have an early recognition of the disease. We have early hospital admission in a very high, huge ICU capacity. We have at least 25,000 ICU beds capacity in Germany, which can be counted to be even more. So the data reported in the graphic are true COVID mortality. So there are not comorbidities on top of COVID cases and the other way around. I mean, people, they die because of pneumonia, pneumococcus pneumonia, and then you diagnose a COVID or the other way around. Probably we are expecting an increase of mortality when all population will be involved and screened as well as the young population, because you need to go to special places, not only direct to the hospital. And one, my personal opinion is most of the German people do respect the rules. That means they keep distance and they stay at home. We have not a lockdown at the moment in Germany. We have a shutdown, but we are allowed to walk, at least in the forest, about the 2 people. But most of the people is taking respect of the rules. The next data. Now I'm going to talking about organ donation in Germany. So the German disease donor rates are minimally decreased. You know very well that the German rates in Germany, the donation rates in Germany are very poor, so we don't need to talk about that. All disease donors are being tested with nasopharyngeal swab and then PCR. Next one. Thorax CT scan has been performed whenever possible, but it's not mandatory unless the surgeon, the thoracic surgeon, requests. Only COVID negative disease donors are located, and you have to think that organ procurement and allocation will be postponed until the results are available. That means a big efforts of logistics. The next one. How is the transplant activity in Germany? So this is a sort of a mini survey I made with our friends from the centers mentioned above. So in few words, the German Transplant Society does provide any sort of SOP, but give just general suggestion. And few centers have single center SOP. So in general, at the moment, transplant activity is still ongoing in all German centers. Next one. Which is the common approach to organ recipients. So when the recipient gets a call, it's been asked about specific COVID anamnesis, symptoms, contact with COVID patient, and risk area. If all the symptoms is negative and the patient is asymptomatic, is get admitted to the transplant center, where he gets a swab PCR test, clinical investigation, X-ray of the lungs, or even in case, if needed, CT scan. And then we perform the transplantation only in case of negativity. Also, this is important to know, it costs a lot of amount of organization and logistic according to the availability of the tests. So in few words, we have a partial limitation of transplant activity and mainly according to ICU availability. Regarding the liver, we perform liver transplantation for high urgency, high MELD patient, but we have to consider also the clinical need. I'd like to discuss with you if it's right to perform liver transplantation in high MELD patients who are going to occupy a bed at ICU for many days, if not weeks, and why not to decide for other patients with lower MELD, but the high MELD are in clinical need. Kidney only deceased donor kidney transplantation, and the suggestion is to avoid high immunized patients with who need ATG induction. Next one. The living donor liver transplantation is going to be performed only in emergency cases whenever deceased donor is not available. And the next one. And most of the living donor kidney transplantation have been stopped. Next one. These are the sources, and most of the German centers do consider the paper in AJT, the recent paper in AJT, and I'd like to discuss with you probably afterwards. There will be the topic about ethical aspect in this situation. I hope we are going to discuss this fantastic paper, which I suggest to all of you to read when in case to perform some triage. For my part is now supposed to be over. Thank you for in case supposed to get some question.
Thank you very much. We're actually looking forward to this live discussion that I anticipate will happen. But I have a question myself. So we have focused on the recipient, but about self-care, because in transplant, we have a tendency to think that we are superhuman performers, but we too get sick and then we become a harm to the others. To remain on the ethical duty, we have a duty to not be an illness vector in clinics and hospitals. Find other ways to help, use telemedicine or other ways. What are your thoughts and your suggestions?
So my suggestions are, maybe I have a slide somewhere, which is the last but one slide, no? Or if you go back to the presentation.
Yes, but we would like to hear from your voice live.
Yes. Okay. So my position is, so in few words, take care of yourself, guys. So so we are not heroes, so we are not gods. So we need to take care of ourselves, and we need to perform to be care to self-protection and keeping distance to the patient. We have to consider ourselves as potential carrier and so carriers, and we have to protect the next one to us. We have to avoid crowded meetings, and so therefore social media. So seems as you do that to use. And so the final suggestion is pay attention and take care of people who are supposed to help you, but are more dangerous than you think. I had a nice picture from a Second World War, but I don't know where it's gone, but I'd like to show you. This is my opinion about that.
Well, thank you very much. And Francesco.
Yes, here I am. Now I would like to introduce Professor Taizo Hibi, who is a pediatric and adult transplant from Kumamoto University in Japan. Professor Hibe will speak about Japanese Transplant Society task force during COVID-19 pandemic. Please, Taizo. Maybe the microphone.
Hi. Good morning and evening, everyone. I'm Taizo Hibi. I'm a liver transplant surgeon in Japan. I really would like to thank Irene and Francesco, Chiara and Paolo for kindly inviting me. I also would like to thank the leaderships of ESOT for organizing this webinar at the critical moment of our battle against COVID-19. Well, unfortunately in Japan, the situation has rapidly evolved and going south during the past few weeks. I have to say that it's the night before the war, and today I would like to share with you what we're preparing right now for the upcoming crisis. So this is the website showing the latest trend of COVID-19 outbreak in Japan. I got this image 6 hours ago, and in only a matter of few hours, the total confirmed cases have climbed up to more than 4,000 cases nationwide. So the map in the middle is showing the hotspots in Japan. The news just came out a few hours back that Prime Minister Abe will declare the state of emergency tomorrow in these 7 big cities, which should have been done weeks ago, and is unfortunately desperately slow from the healthcare viewpoint. Next slide, please. Thank you. So up until the end of February, although we did witness a gradual increase of infected patients, we thought the situation was still in our hands. Well, as you know, we do not hug each other nor shake hands so often, not because we're cold-blooded people, but because most of us were taught to respect personal space since childhood. And most of the Japanese are good at coughing etiquette and hand hygiene. So to a certain point, our culture was an advantage to contain COVID-19, but it turned out that it was not effective enough. So in only a matter of 1 month, the number of infected people has shown 10-fold increase, and now we have more than 4,000 patients. And as of today, we have lost 70 people with a mortality rate of 1.8%. So what is the imminent danger in Japan? Compared to the countries in Europe, we have very low number of ICU beds. And on top of that, Japan is the #1 Asian country, and approximately 1/3 of the whole population is over 65 years old, meaning that there's a higher chance for the hospitals in Japan to take care of critically ill COVID-19 infected patients needing ventilators and ICU beds. Next slide, please. So for the next 2 slides, I'll summarize the guidelines established by JST, Japan's Society for Transplantation, that was released 1 month ago. So for a living donor kidney, intestine, and pancreas, which are non-vital organs, we documented to postpone those cases. And for lung and liver, after informing both donors and recipients of the risks of COVID-19 transmission and post-transplant infection, centers can proceed with caution. And we also recommended that donors and recipient candidates should stay home or at a medical facility for 14 days. That means the incubation period prior to the date of transplantation. Next slide, please. So how about deceased donors? Well, as most of you are aware of this, we have extremely low number of deceased donors. However, we decided to adopt pretty much the same principle with living donors. So obviously, if a potential donor is suspected to have a COVID-19 infection, organ donation would be canceled. So at the moment in Japan, a PCR test is not mandatory for all cases. So this is a recommendation that we have. Can you forward the slide, please? Thank you. But in reality, rules are rules, and basically we have to weigh the risks and benefits on case-by-case basis. When we think about, like I said, the extremely low, long waiting time for each organ. So for example, for heart, the average waiting time is over 3 years, and over 90% of these patients are status 1 patients. And for liver, it's over 1 year. It's the average waiting time. So it's totally okay if the transplant center decides to carry on with either kidney, intestine, or pancreas transplant with a deceased donor when the team considers benefit outweighs risks in a specific patient. Next slide, please. So this is the last slide of my presentation. JST has decided to launch a national registry of COVID-19 infected recipients to help transplant centers keep track of COVID-19 infected recipients and what we should do to those patients. And in addition, Japan Surgical Society has released the first version of Principles of Surgery last week to prepare for the crisis, which many parts were adopted from either from the US or European guidelines. So it's time to consolidate global effort to put an end to this war. Thank you for your kind attention.
Thank you, Professor Hibby, for the fantastic presentation. I have a very short question. So you talk about general policy and guidelines for living donor in terms of screening and prevention, but who we should transplant?
So at the moment, it is totally dependent on transplant centers which patient they should pick. Basically, for a living donor, either lung or liver transplantation, the order of the patient is first come, first served. So we really don't care if the patient is very sick or fairly stable. If we think it's time to go for transplant, we just go for transplant. So what's different at this time frame is that we will inform both the donor and the recipient about the risks of COVID-19 transmission and also post-transplant infection of COVID-19. So that's pretty much the only difference that we have at the moment. But things can change. So like I said in the beginning, those big cities in Japan, they're in the emergency state. So in the long run, we might change our policy. But at the moment, we will proceed with living donor liver transplant and also lung transplantation.
Okay, thank you very much, Irene. If you want to introduce the next.
Thank you.
Thank you, Taizo, and thank you, Francesco. So I'd like now to introduce Peter Nickerson, who is the medical advisor of the Canadian Blood Services and also professor of medicine, Rady Faculty of Health Science, University of Manitoba, who will talk about COVID-19 in Canada and for highly sensitized kidney transplant candidates.
Thanks very much for the kind invitation to attend ESOT's webinar today. In Canada, we're also experiencing a rapid spread of COVID across the country. To date, we are at 16,000 cases and 300 deaths, giving us a mortality rate so far of 1.8%. We've been in lockdown for about 2 weeks across the country, and I was specifically asked to talk about what are we doing around highly sensitized patients. Well, our strategies up till now have been two major national programs. One is the National Kidney Pair Donation Program, where you can see that over the years, we've been doing about 80 of these transplants per year. And as of 16th of March, nationally, Canadian Blood Services, in consultation with the community, decided that this program should be shut down for at least 6 weeks until we see where we're at. The reasons for this was the amount of donor travel that we were doing as a part of our paired donation program. We felt that having the living donor travel was really too high risk, given the crowded circumstances and the ongoing community spread that we're seeing now for COVID. Next slide, please. The other program is our national deceased donor organ sharing for highly sensitized patients. And again, we've been launching this for the last 10 years. We've done currently almost 600 transplants over several years. And you can see that we're doing about 100 kidneys a year through this program and getting some very highly sensitized patients transplanted, especially in the 99 and 100% categories. And yet we still have many patients accumulated on the wait list, over almost 400 at 100% PRA. Next slide, please. So we've been in discussions on a bi-weekly basis talking about the status of all the programs in Canada. And what I'm giving you here is the national dashboard that we have. What the first thing I'll say is that accepting organs from the US, we have had trans-border shipping of organs, especially lungs and hearts, but that has essentially shut down except for on a very rare case-by-case basis with Alberta, given the high prevalence that we're seeing in the US, and even interprovincial sharing between provinces where there's a high prevalence, especially in Quebec. the interprovincial sharing of organs has diminished. In terms of kidney, as you can see, the LD or living donors are all red dots. We've closed down all the programs in Canada. For deceased donation kidneys, the DD for kidney, again, it's predominantly red dots. Alberta remains open on a case-by-case basis. For highly sensitized, the country is split. About half the country has shut down even its highly sensitized offers to patients, whereas others are doing it on a case-by-case basis. And all of us remain open for medically urgent kidney where patients are running out of access. Next slide, please. So what it's come down to for us, and these are guidelines, consensus guidance from the Canadian Society of Transplant in association with Canadian Blood Services, is what are the criteria for going forward with a deceased donor? Specifically, what we've identified is no travel outside of Canada in the last 14 days. Many of the cases in Canada are from Canadians returning from holidays, especially in the South. There has to be a screening history. It's negative, not suggestive of COVID. And now, like many countries, we require deceased donor testing for COVID-19, negative by a nasopharyngeal swab and by a BAL or an endotracheal aspirate as well. Now, if the person, and I think this is going to become more the case as time goes by, if they've had prior COVID positive and they're now currently asymptomatic, we would require negative COVID by nasopharyngeal swab for 2 tests. In terms of recipient criteria within the HSP, or if they were on the deceased donor list, this has become very highly selective. Again, we want the recipients not to have traveled outside of Canada in the last 14 days. The screening history has to be negative, and the COVID test is recommended that that be negative by nasopharyngeal swab. In terms of the HSP, most patients, most programs will only transplant at 99% or higher. They're looking for predominantly healthy individuals who are highly sensitized, so they're going for the younger recipients. They're trying to avoid those with major comorbidities that put them at increased risk. And like others, we are avoiding depletional induction therapy. So for those that we're really sure that there's no memory against the donor, and we don't have to use depletional induction, they would be going forward. And one of the things that we've been insisting is that there be informed consent about the post-transplant risk for acquiring COVID, depending upon the community prevalence in our populations across the country. And with that, I'll stop and take questions.
Well, thank you very much for being so sharp and direct to the point. We really appreciate it. I've got a question. So teams feel rushed to take organs not thoroughly screened, and also low volume centers might take anything they are offered just to keep their programs running. What are your views, particularly with regard to this?
Yeah, so that's been a great debate, Irini, across Canada. And what we have all come to the consensus is that you must do the COVID testing of the potential recipient to make sure that they are not themselves not infected at the time of transplant. And we can get the turnaround time within 24 hours, and everybody feels that that's sufficient to be able to ensure that this test must be required. In terms of just going ahead for the sake of going ahead, when you have an offer, the programs have been actually very against that. What we're all facing over the next 4 weeks is an increasing prevalence of COVID in the population. And we recognize, as has already been mentioned from the Italian experience, that in-hospital spread of COVID will likely be a major risk factor. And so having patients that are going to be in hospital or are being forced to come back to clinic regularly, especially in the first month post-transplant, given the current status of where we're at in our COVID epidemic in Canada, we're really being very selective, and I would urge everyone to be selective, especially in this upswing phase of when we're experiencing COVID.
Thank you very much, and yes, we totally agree about being very selective. Okay, Peter, I now would like to introduce our next speaker. We're still in the North America area with Saima Aslam, Medical Director of Solid Organ Transplant Infectious Disease Division of Infectious Disease and Global Public Health University of California in San Diego, US, who will talk about the COVID-19 outbreak in the US, containment and mitigation measures for transplant programs. Simon?
Thank you very much. Yes, I hope you can hear me. So good evening to everyone. I'd like to start off by thanking the organizers for inviting me to attend this ESOT webinar. What I'd like to do is give you a brief snapshot of COVID-19 in the United States and then its impact on transplant activity. So, you know, the US is a huge country, and unfortunately, when compared to our colleagues in Europe, we're still in the beginning phases of our pandemic. And even within this beginning phase, you can see we've now reached, and this is, you know, data from a day ago, we are over 300,000 cases with unfortunately more than 8,500 deaths. Our first case was reported in actually January, so end of January 2020. And unfortunately, at that time, effective containment strategies were not pursued. And it's only very recently that we're trying to pursue a mitigation strategy. And so because of how our country is organized, mitigation strategies are very different across different states. And as you can see, currently our biggest hotspot is New York City, which is that large circle on your right, the red one. Currently, about half of the cases in the United States are in New York City and the surrounding areas, and about half of the deaths are in that place as well. We have a couple of other emerging hotspots, which are circled in blue. So in the north, it's Detroit and Michigan, and in the south, New Orleans in Louisiana. And both of these, unfortunately, the rate of increase of new cases is actually faster than that of New York City. And so currently in the United States, what we're seeing, instead of one sort of overall pandemic, we actually have small or different areas of outbreaks in different parts of the country that are basically proceeding at different rates. Could you go on to the next slide? So one of our biggest problems, and this continues to be a problem, is lack of effective testing. And so when initially the first few cases were noted in end of January as well as early February, testing kits for SARS-CoV-2 was available only from the CDC. So it was national test kits that were shipped out to public health authorities, you know, within the United States. So that was the only place to get testing. It was very limited, and there was very strict criteria on who could be tested. In general, at the time, we were testing people that were only traveling to high-risk areas. At that time, China and Italy and Iran, among others. And so towards February and early March is when we, you know, obviously have now more testing abilities, more testing sites, but the limitations remained in terms of criteria. And so we continued to test a very limited subset of patients that probably were infected. And so the main criteria at the time was fever and cough. And I think we now have enough publications showing that this is really a very limited subset. And there is unfortunately a large amount of pre-symptomatic and asymptomatic transmission of SARS-CoV-2 in the community. So currently, we now do have mitigation strategies across various states. So here in California, we actually went in lockdown 3 weeks ago. And I think that's helped reduce the pressure in our hospitals. There are other states where, despite increasing cases, you know, some states and cities are still not in lockdown. Testing still remains very problematic. And I think one of the issues is just a restrictive regulatory culture in which each test has to be, you know, vetted by a central authority. And there has been some loosening in limitations of that or regulations so that tests can come to market quickly. However, you know, despite the case load I showed you, more than 300,000, we expect the figure to be 4 to 5 times higher because of limited testing that's currently ongoing. Next slide, please. So the effect on transplant. So, you know, currently, due to limited testing, we've had limited testing both in donors and recipients as well. We do not have, I mean, we have guidance from the American Society of Transplant, but in terms of actual enrolling out, you know, these guidelines within local center policies, I think is different and based on what a center decides to do. Despite that, deceased donor testing only recently over the past week, I think, is now available within, you know, throughout the United States. Previously, it was in very few areas. Living kidney remains on hold, as other speakers talked about in their countries, especially in areas with high rates of local transmission. And the recommendation is to really pursue local recovery of organs rather than have recovery teams fly out to different sites to collect organs. So on the right, you see the figures that show our year-to-date cumulative transplant. The green line is for 2020, and this is national data from UNOS. You can see for green, we started off good and we were doing a lot of transplants, but by early March, it's coming down significantly. And so you can see most of this is driven by the reduction or the cessation of living donor transplants. So you can see at the bottom left figure. Deceased donors are being affected as well, and we expect over the next 2 months that the green line will dip down below the 2019 numbers. Next slide. So this looks at the effect on the wait list. So UNOS introduced in the beginning of March specific codes that programs or centers could enter that made it obvious if waitlisted candidates were being inactivated due to the COVID-19 pandemic. And so that was introduced March 8, and you can see we had a large number of waitlist candidates that were inactive on the list. This has come down somewhat, and I suspect the reason why we're now activating more than we did at the beginning of March is because of widespread deceased donor testing that's now available. That was not available at the beginning of March, or actually the first half of March. You can see the effect on new additions to the waitlist, which is the green line, which is trending down. So less people are now being added to the waitlist. And then inactivation rates for other reasons is going down as inactivation for COVID-19 goes up. Next slide. So I'm going to talk about organ offer policies. So these tend to be local. I mean, we have one at UCSD, at University of California, San Diego, that was shared with you. But part of the reason why some of these policies are local and not statewide or national, I think, is based on the resources that are available to each center. And so again, the biggest limitations driving local policy are the availability of both the deceased donor testing as well as testing of asymptomatic waitlisted candidates. So at our center, it's only this past Monday that we actually started testing asymptomatic waitlisted candidates. I think the other limitation is the turnaround time for tests. Within the US, this turnaround time is very variable, and so ranges anywhere between 12 hours to 7 days. And obviously the availability of OR, ICU space, as well as other medical resources plays a role in how we continue to transplant. And again, we have, unfortunately, a huge limitation in personal protective equipment. The sum of the limitation in transplant or proceeding with surgery is also going to be related to how protected or how much can we actually protect our healthcare medical teams and not have them exposed unnecessarily. And then also the locality is due to the degree of COVID-19 in the local community. And for us, and as well as other centers, this is continually reassessed and I think readjusted probably on a daily or weekly basis at least. And so I think, a few of the speakers talked about it, and I think the webinar will discuss later, there really is a very strong need to develop cohesive ethical policies and how we want to prioritize our waitlisted candidates, given that we do expect rationing of transplant resources. Certainly we've seen that in Italy, we're seeing that in New York City, and probably we'll be seeing it in other places as well. So I'd like to go over this flow sheet. It's a little, I think, small to read, but in general, what we decided to do for our center was we have not really inactivated people because of COVID-19 unless they are medically well and we feel it's safe for them to defer transplant for the next 3 months. So when an organ offer is available, we first have the coordinator call the patient, reach out to them to assess for symptoms of COVID-19, to assess for contact to a confirmed case or sick contacts, as well as travel history. If symptoms are present, we probably would defer transplant and investigate further. But it really is the asymptomatic people we want coming in for transplant surgery. And then again, just last week, we've now started testing these asymptomatic patients. Our testing turnaround is not sufficient. This week we expect it to be around 8 hours, but last week it was 12 to 24. And so we decided for kidneys, we have the time to wait. For other organs, we were going to proceed, but potentially adjust immunosuppression post-transplant. So currently at UCSD, all our living donors are on hold. For livers, we're prioritizing high MELDs. We're continuing to do all lungs and hearts with adequate testing of both the deceased donor and recipient. And we have reduced our waitlist activity in terms of new additions and are focusing on those that would really benefit from transplant within the next few months. Next slide. And thank you very much. I will end here and see if there are questions.
Well, thank you very much. We really appreciate this insight in the US that now undoubtedly is just the main, I would say, epicenter of the pandemic. But we have just a short question about healthy living donors who would be willing to donate. Is the risk of infection acceptable during COVID-19 pandemic for healthy living donors?
So what we decided within our center, and I think this is true for most centers, we're worried about our living donors in particular. I think our first goal is do no harm. And so I believe given the amount of ongoing transmission, it's best for our living donors to stay at home and remain socially isolated rather than having them leave the house and come in for surgery that is elective. So I don't think, within the US for sure, the risk of them developing COVID-19 is not worth for them to come to the hospital setting and be exposed or within clinic visits, etc.
Thank you very much. And we'll go back to Europe with Francesco.
Yeah, so now we are going to Spain with the Professor Paredes, who is a nephrologist and consultant in donation and transplant coordinator from Barcelona. Professor Paredes will talk about the organization of the exchange of organs at a national and international level. Please, Professor.
Thank you so much, Francesco, for this kind presentation, and also to ESOT for the invitation to participate in the webinar, and all the other participants all around the world, to Irene for all the organization, and Luca and all the people from ESOT. Thank you so much to all the attendees for being with us. And I would like to present what is the experience from Spain. You will see that it is very similar to what is happening in other countries, particularly very similar to Italy. You can see in this slide that is written in Spanish, but that means that the cumulative incidence and mortality rate in Spain has been a high cumulative incidence of COVID infection, and the mortality rate is not as high as has been in Italy, but is still very, very high. And the big problem is that this situation have created the importance of early detection of the cases. And 3 weeks ago, we have started the lockdown all around the country. And now it has been extended for 2 weeks more. And probably will be extended even 1 week more. But the problem, the situation is that in confronting all these problems, we have been, the next slide please, we have been developing to answer to this situation altogether contingencies measures that has been a result of the scenario number 4 that is described in this interesting description of the European Center for Disease Control, that is explaining all the biggest scenario that the country is confronting, especially in the well system and in the intensive care setting that has been carefully described before. In this particular point, what is happening? We need to make contingency measures for the ICU, and that's why the Spanish Society of Intensive Medical Care and Emergency, together with the National Transplant Organization and with the group dedicated to infections in donation and transplantation, have created all these kind of measures that will be presented shortly later. As well, we have created multidisciplinary teams, not only inside the transplant hospital, but as well has been promoted regionally and nationally to work together and to create harmonization of what we should do all together to reduce the impact of the COVID in organ and tissue, not only organs, but as well in tissue, donation and transplantation activity. And of course, we should focus in the safety and security for the waiting list recipients and as well for the transplant patients, and particularly, as it has been described and will be commented later, the safety and security for transplant teams. The next one, that shows the next slide, thank you. That shows at the upper part in the left-hand side, you can see how is the composition of the donor coordination teams in Spain. We have 185 donor coordination teams all around the country, and has been increasing the number all around the years. And particularly most of the people, especially 337 physicians, 95% of them are fully dedicated to intensive care and as well dedicated to organ donation. That means that the donation becomes an integral part of the end of life, and that is why we are so involved, and we have these big results in organ donation in the country. But as well, we have a big collaboration from nurses, and half part of our teams are composed for nurses, with 75% of them fully dedicated to organ donation. So what we have done from the donor coordination teams to be involved and to fight against COVID pandemic, we don't need to make a big transformation to continuous working in the ICU, but we should focus to dedicate to intensive care treatment for the COVID patient. But at the same time, we need to convert ourselves to a donor tax, very important, to make, as we have done in our hospital, where we are only full-time dedicated to donation. We don't work in the intensive care, but we are fully time dedicated for donation as an integral part of the organization in the hospital. And then we are giving support and care to serve as a bridge for communication between the ICU health professionals and the relatives of patients in the ICU. Remember that the relatives are totally locked down and they cannot see their relative, they cannot see what is happening, they cannot say what is, be with them, and they cannot say goodbye when the patient passes away. So in this terrible situation, we are bringing support and communicative tools to the families, even using sometimes continuous telephonic calls that is complex to manage, and as well to communicate sometimes with them using WhatsApp or using cameras or tablets or multimedia. And as well, we are helping the hospital organization to help to arrange the funeral, the relatives for funeral arrangement for all the pandemic-related deaths with a high impact in the activity in the funeral homes, etc., that have created a big difficulties. And we are helping the hospital in solve all these situations because we know how to deal with all these critical situation in the grieving process. The next one, and then what have been done in the country? In the country, we have been created this increased communication between all the stakeholders and all the participants in the donation process. It is starting very early at the end of February with the national widespread of the dissemination of documents, like it has been presented by Italy or the States, etc. With is very similar how we evaluate the deceased donor, with a continuous advice of multidisciplinary teams to reduce the transplant team's mobility and increase local retrieval for all organs, and send the organ traveling alone, especially particularly curious for the heart and the lungs, that usually is the transplant team who goes to procure the organ to the other center. Of course, we need to make case-by-case donor evaluation, but particularly we focus in ideal donors. So the uncontrolled TCD program that is particularly strong in Barcelona, Madrid, and in the northern part of the country has been stopped, the uncontrolled DCD. But for brain death, we focus especially on ideal donors, and in the control DCD from the ICU, we focus as well in the most efficient way to utilize the resources, especially particularly confronting when we have a very busy ICU. As well, we are done an early search for transplant team availability even before finished all the total evaluation of the donor, so that the transplant teams can start doing the evaluation of the transplant recipient, and with an early HLA typing and cross-match, and of course to introduce flexibility, initiative, and adaptation for organ allocation and sharing using what is happening all around in the airports, in the transportations, how to solve all these difficulties. And we have observed a reduction in the potential disease donor cases that are entering to the hospital. What is happening? Maybe they remain at home, they are transferred to another hospital, not to the main transplant hospital. We don't know exactly, but it's something to be evaluated in the future. The next one, it tells that at the same time, in the next slide, please, you will see that when we are confronting to the transplant recipient, we have organized in the hospitals, in the transplant hospitals, and as well with national transplant guidelines to increase communication and information for recipients on the waiting list, particularly for the living-saving programs like heart, lung, and for liver, and with a continuous advice multidisciplinary team working by teleconferences and continuous update of the ICU facilities, and always having, as has been explained by Professor Shilo from Italy, an available operating room COVID-free with a ward and post-transplant area for these recipients. And we focus especially for transplantation in emergency cases and vulnerable groups, as has been previously described by the other speakers. With a case-by-case recipient evaluation, careful evaluation of the to avoid cases of patient exposed to COVID or that is positive to avoid complications, and elective kidney and simultaneous pancreas kidney has been reduced or almost stopped in all around the country. And we have started a follow-up and registry of transplant patients infected together with the ONT and the infection disease. You can see, as happened in Italy, a big reduction in the activity in the country from 180 donors to 20, and all has been a big reduction in transplantation and donation. The next one, you can see what is happening in Europe. In Europe, all around the continent, it has been a very interesting document from the ECDC, is the supply of substance of human origin in the European Union. That is very important that as well, a note from the European Commission about the cross-border shipment of human origin substances, and is the increased communication between all the national transplant offices in Eurotransplant, the Central Nazionale di Trapianto in Italy, Agence de la Biomedicine in France, the National Helablon Service in UK, and as well in Scandia Transplant in Spain, in Portugal. All together, we're talking with continuous advice from sharing what is doing all the countries, and case-by-case donor evaluation. And of course, we are looking for organ acceptance and sharing with neighboring countries. And in the same countries, almost all the teams are reducing mobility, except in countries with very low rate of the peak of incidence.
We are 2 minutes out.
Okay, I will finish soon. In the Scandia transplant area. So just to finalize, don't only focus on organs. Always remember the importance of tissues like the bone marrow donors that has been some cases of transportation using the military airplanes. Thank you for your attention.
Thank you, Professor Paredes. My question is about safety of people involved in the retrieval process and travel of the organs. So what do you think the best approach? Because different countries have different policies in these regards.
It is important that each team has his own protocol. They need to be prepared and make simulation and prepare to be organized to have a COVID-free area from the operating room, the ICU area, and then the post-transplant ward, and as well to avoid mobilization of the recipients, along mobilization and transportation using telemedicine. And they need to create, to evaluate also the health professionals working in the transplant teams and in the donation team as well, to evaluate and to avoid contact with positive person that will be asymptomatic.
Okay, thank you very much. And I think, Irene, now we are going to introduce the topic.
Yes, on resource distribution. Thank you very much to all the speakers who have given us 360 degrees insight from all over the world. Now we would like to focus more on what are the three main parts that are involved into the decision making. And when we talk about transplantation, we have, of course, the transplant surgeon, but we have also the ICU colleagues and those who are supposed to give their view on how ethical is our care and our behavior. So I would like to introduce our first speaker, Francesca Rugulotta, an intensive care medicine consultant at Imperial College London. We know that at the moment London is really an area that is suffering with the COVID-19 outbreak. So please, Francesca, to you for the ICU point of view.
Thank you very much, Professor Bellini and Giovinazzi. Thank you very much to the Society for inviting me. I have nothing to disclose, except I am not a surgeon, as you said in the introduction. My background is anesthesia and critical care. So I've been asked to talk about resources distribution. And at the beginning of this pandemic, the focus was on ventilators. In fact, the number of ventilators was mostly representation of the quality of care provided and the plan in place in the country for saving sick individuals coming to hospital. Unfortunately, later in the pandemic, you see that more and more frequently the faces of healthcare providers scarred by personal protective equipment came into the press. And in fact, we realized sadly that many more resources are needed to care for COVID-19 patients admitted to the intensive care unit. And you will see that those professionals are now considered lucky for having protective devices, because several or many across the globe are still in the unit working without sufficient mask and sufficient protection. And we see in Italy that more than 130 healthcare professionals died, and we can see sadly in London several of our colleagues being admitted to hospital and even being intubated. This is causing fear at the moment, and certainly will cause long-term distress into the healthcare professionals that are fighting at the moment the disease. At the bottom of this slide, you can see also bed represent limiting factors. And this is a slide I've taken from my colleagues in Milan showing a patient prone and ventilated on an ambulance bed. In the next slide, you can see the trend showing the number of admissions increasing fast across the 3 sites at Imperial College in London. And the response of the national healthcare at the moment has been quite peculiar. This is a busy slide on the right, but it's just showing that the first answer to the crisis has been increasing the nurse to patient ratio from 1 to 1 to 1 to 6, and the intensive care consultant to patient ratio to from 1 to 10 to 1 to 60. So this means that we need to spend very little time to look after those patients that actually are the most challenging at the moment in our hospital. In the next slides, I very quickly would like to give you, next slide, I give you an example on how I describe to my patients what the meaning of intubation, ventilation is when they suffer of acute respiratory distress syndrome. I think the closest similarity is the one with flying. So when the tube is inserted, for us, is taking off. After the tube is in place, we need to maintain the flight in the direction of a journey that ends at the time that the lung is recovering, or we feel as healed enough to allow extubation. Extubation represents landing, and in fact, landing is more challenging than taking off. In particular for these patients, we have ICNARC data showing that COVID-19 patients can be ventilated 2 to 3 weeks, and they require a huge amount of interaction and physiotherapy to come off the ventilator. The extubation and reintubation rate of these patients is much higher than the normal population. Therefore, the work around those patients is extremely exhausting. It's physically and mentally exhausting, and is done in extreme conditions. And landing sometimes sadly represents even withholding care to allow other people that might benefit more to use the ventilator. These are choices they need to be made on a daily basis and cannot be done in 10 minutes like some of the managers are requesting us to do at the moment. In the next slide, you can see that anyway, the work goes quite fast. It's quite intense. This picture comes again from our colleague in Milan. But how can we contain the virus into this type of settings? At the beginning of the pandemic, a lot of work has been done trying to create negative pressure isolation room in order to contain the virus and to limit the spread from these patients. If I had to design the unit now, I would have done the complete opposite, because now we see that our hospitals are completely filled with COVID patients. They are in any ward, they are in any part, they are completely invade our intensive care unit. So it's becoming very challenging to protect non-COVID patients from having the infection in the hospital. So what I would have done, knowing it's now, would have been to create positive pressure isolation room for the non-COVID, non-infected patient. In the next slide, you can see that it's quite challenging for a patient to come today to hospital, especially if they want to receive a new organ. And this is just a summary of the challenges across the whole pathway. The community is not tested. Very few countries are investing in checking the amount of infected and contaminated people in the community. So the quality and the donors that come to hospital are very difficult to assess. So the number of organs is decreasing worldwide. What about the recipient? If they come to hospital, we saw from previous speaker that there are techniques and methods to assess them, but what about the family? And how can we make sure they have not been, or they will not be exposed? And even if they are successful in receiving their organ and they get reintegrated into the community, the risk of dying if they get infected after hospital discharge is much higher of the common population. And in the time of the pandemic, actually, they will struggle to find a bed in the intensive care unit. So what could be the solution? In the next slide, one of the possible solutions is that of creating clean hospitals. That is what NHS is trying to do with partnership with private hospitals, where actually we are trying to move the elective surgery, not just the transplantation, but even the trauma or the oncology or the cardiac surgery. If this is not a possibility in your country, the advice is that of creating clean teams dedicated just to treat patients that are not COVID. These are rare, and you will see the more cases you have in your hospital, how difficult it is ethically now treat those patients, because not even all healthcare providers are tested. And this is absolutely something I would like to pick up in the discussion and maybe explore further. What a clean team means is a team of people that are not infected, need to be strictly isolated, and need to be available in a very different work schedule, smart working for doctors too. And we can talk about later on how frequently the team should be tested and how frequently the patient should be tested. In the last slide, I try to stay in time, regardless the fact I am from the south of Italy. I would just like to conclude by giving you an advice that comes also from our experience. If you have not done it yet, my advice, please, is start using simulation for checking and testing how your hospital works, but not for procedural simulation like intubation, but for multi-specialty and multi activity, such as transferring a patient from a ward to the intensive care. You will see how challenging this can be, how many people need to be involved, including cleaning, security, elevators. So design and try those pathways, because you want to guarantee that patients that are not infected don't get infected while in the hospital. It's ethically unfair, it's designed wrong, and is happening every single day across the world. And I think if we don't rectify this or find solution around this, it's very unlikely that we can guarantee good transplantation of good care of patients that are not sick. And with this, I think I've been keeping in time, and I'm very pleased if you want to ask me questions. Thank you very much.
Well, thank you, Francesca. We really appreciate this insight from the ICU point of view, because we as surgeons actually have not that perspective. But just to remain on the topic, During COVID-19 crisis, should we consider business as usual with ITU reserved resources for transplant programs like normally most of the transplant programs have, or should we adopt the principle of capacity to benefit?
A short answer to your question is nothing is as normal during the pandemic of COVID-19. Even the most simple things are extremely challenging, and it needs to be done extremely fast, and everyone is extremely exhausted. So business as usual is not possible, and it's also dangerous. I think ethically transplants needs to be continued, but we need to guarantee that it's done in a safe environment, in a safe manner, because we cannot do it without having into place a clear plan and a clear testing of the staff and the patients. This is not the case, at least in England at the moment, so I feel not a safe procedure to do everywhere. If you can guarantee clean hospital, or if you can guarantee oasis dedicated for this type of business, please carry on. But be responsible is my point.
Thank you, Francesca, and I leave to Francesco now.
Yes, thank you, Irene. So I would like to introduce Professor Muyasan, who has been my mentor in Birmingham. And he will talk about the point of view of a transplant surgeon in this emergency situation. Please, Professor Muyasan. The microphone? Maybe the microphone?
Now they allow me to use the microphone. Thank you, Francesco. Thanks, Irene, for the kind invitation. It was very interesting, the first talk. And I have to say, in countries in Europe right now, it's extremely difficult to find a safe environment. And we have to accept that all this surgery, and I'll come back to it, it's at higher risk. But I'll go straight to the main point, really, which is, and unfortunately I have in my slides, I put some animation, so we'll have to click a little bit more. It's that my main point of view is that medical workers have not been valued and protected appropriately in this crisis. Doctors and nurses have done their jobs without having the appropriate personal protection equipment, at least at the start, but even now. And the worst issue is that they've been actively discouraged to do so. So colleagues of mine have been told in different countries, not just in the UK or US, but also in Italy, not to wear masks to avoid alarming patients. And I think this has been a big mistake by managers, because a sick doctor is not good to anyone. And unfortunately, mortality, and this is, as we already touched on this, has been very high among our profession. I calculated probably at this point, 89 doctors have died in Italy, and I think at least 25 nurses. Can we go next? Unfortunately, these are the pictures of doctors that have been suspended for wearing masks, if you can believe that. And the next one is a picture of a transplant surgeon that died in the UK. Next slide, please. And protection for health workers have been recommended in numerous guidelines from a number of scientific societies. And of course, the most sensible ones start from maintaining a minimum number of staff in the operating room, offering full personal protection for positive or suspected positive patients. And this is, I've tried it. And as you can see in the right side, that picture is me. With full PPE, tasks become more difficult and slower, so that there may be a need for team changes for long and complex procedures. That day I did a procedure of 2.5 hours, and it's very difficult also to undress in the appropriate way. And I was completely wet and really difficult to concentrate, to breathe, and to see through the goggles. Laparoscopy should be avoided as it generates aerosol, we know that, and should be used only if the clinical benefit is greater than the risk of viral transmission. And I also think that repeat PCR testing, and this is really important, for asymptomatic medical workers is essential. This is essential, and still a lot of hospitals and in many countries do not understand that. Next slide. In terms of COVID-19 and transplant recipients, we don't know much in regards of transplant recipients and COVID-19. It's obvious that the transplant recipients are a particularly vulnerable group of people. It has also been suggested that immunosuppressed children may have lower risks than the adult population. That has been suggested without a big data really by the pathologists in Bergamo. What we know so far comes from COVID-19 transplant registry instituted by the University of Washington. The essential information regards 75 reports, including 10 recent transplants. Of these, of course, the majority would be kidney transplants. The mean age is young, only 54 years, and 1/3 of them is in intensive care. 16% of them are intubated. Half of them have got lymphopenia, which we understand may be a poor prognostic factor for COVID-19. And in 2/3, immunosuppression has been modified, mainly by stopping MMF and ASA. Lastly, 3 patients in this registry have died. Now, regarding donors, looking also at, in this case, at the TTS guidelines, the risk of donor-derived transmission is unclear. We know that RNAemia has been reported in at least of 15% in case series. And in high-risk countries, we should really consider temporary suspension of DDLT or deferral for more elective cases. For what matters LDLT, we know that recipient surgery is and may be essential, but donor surgery is not essential. Therefore, we really need to be careful on this. We need to also know that laparoscopic retrieval, which is becoming more popular in donor surgery, should be avoided in these times. And also for all the people that use CUSA, yes, it is an aspirator, so it should not generate that much aerosol, but all it needs is the suction system to block, and we know that that happens quite often, and you have a lot of production of aerosol, and that may be really dangerous. So no LDLT procedure should be carried out with high-risk donor or recipients conditions. We should consider a temporary suspension of LDLT kidney and liver programs. Routine testing should be done in all donors, but I think also in recipients. And in selected cases, in life-saving procedures can be conducted with appropriate assessment of infection in both donor and recipient, and with appropriate informed consent. And I may come back to this point later. Next slide shows a multi-center studies. Next slide, please. Of 17 centers in 12 countries being submitted to right now to an important journal by Glenn Bonney, a colleague of mine in Singapore, and that's on the effects of a viral pandemic on liver transplantation protocols. We know that there is a restriction of ICU beds in these times, and that means reduction in donations and number of transplants. And in Italy, we know already from a letter by Roberta Angelico on AJT published 2 days ago, that there has been a 25% reduction on procured organs in the last 4 weeks since the outbreak. And all I want to show you is really on those 3 columns. The column on the left side, looking at many transplant centers, shows that a completely open transplant centers really not reducing their activity, and that's on the start of the outbreak. The middle column is really at the time of the declaration of the world pandemic by the WHO, and shows how many countries have decided really to limit their transplant activity. Argentina completely locking it down. And as a reaction to the declaration of the pandemic, on the 3rd column, you see what happens, and really some German centers that also decided to reduce and limit their activity, which is what should be done. The last slide, and I'm finished really, it's really to make sure we don't just look at the news and looking at the unfortunately 700, 800, 1,000 new deaths in each country nowadays, but we need to start counting the hidden deaths related to COVID-19. And if you look at this slide, you'll see that in the last 8-10 years in the UK, this is an HSBT slide, a huge progress has been made in donation and number of liver transplants. And in the green line shows you how the waiting lists have improved and gone down. If you press next again, and you'll see that unfortunately the number of transplants will go down quickly, the waiting list will go up, and that will mean only one thing. And again, press next, increase in the waiting list mortality. So practically, we will go back to a condition a few years ago unless we manage to control this problem. And those people that will die, extra people, it's already a 10% mortality. And if that increases, will really bring us back to a few years ago when we were not doing so many transplants. Thank you very much.
Thank you, Professor Buyes, for the very focused presentation. And just a quick question. Should we screen the healthcare providers, in particular surgeons or people involved in transplant?
I think we should screen all the medical workers, really, because, and I think we should screen them with PCR. You know, so far I have not had a PCR, although I had high-risk contacts. And the problem is then we become, you know, the spreaders of the virus, or we need to go home and stay with our families. And not everyone has got, you know, big places where to go home and isolate themselves from the rest of the family. So I think it's paramount, with all the limitation of the screening, that we get screened very often. I think at least once a week.
Okay, thank you very much. And Irene, you want to introduce our last speaker?
Well, the last but not the least, we have talked a lot about ethics, so I'd like to introduce Katrina Bramstedt, professor at Bond University, Queensland in Australia, ethicist, Cedars Sinai Kidney Transplant Team, Los Angeles, US, and chief executive in Luxembourg Agency for Research Integrity, who will talk about the ethics point of view, pandemics, and transplant data, public interest in the duty of care.
Great. Thanks so much for having me. I really do appreciate this opportunity to try to give some insight from the perspective of a transplant ethicist. All right. So with this slide here, it's no secret that all of us in the field of transplant, we are highly competitive. And I think we're a standout really compared to other fields in medicine. The transplantation is hugely competitive. We're always trying to be the best. We're trying to beat other centers with our numbers. There's no question. But I think that during a pandemic, we really do have to make a mental shift from this competitiveness and recognize that our stakeholder pool has really widened, and people outside of our own transplant center need our knowledge and they need our data. And this is in this setting of what we call ethically a public interest duty. So we go now beyond what we always have, which is the duty to care, and we add in what I think is really the duty to share, and that this is what's happening now in this setting of COVID and the pandemic. Next slide, please. And some of this, what I have in my talk today also is coming on the heels of a webinar that was done about a week or 10 days ago by the AST and the ASTS and NATCO and others. And one of the issues that came up was data and data sharing and how people are really scrambling for information. But back to this concept of public interest is why is there a public interest? And it's because, again, transplantation is unique. It's different than other areas of medicine. We really have this community gift. What we work with are things that aren't off the shelf. They're not barcoded, and you can't just order more when you need organs. They're a gift, and the donors and the donor families, I think, really do have an expectation of organ stewardship. Organ stewardship, we know, is partly held by our patients. We expect them to, quote unquote, behave or be compliant and adhere after transplantation, but organ stewardship is also laid on us as healthcare workers so that we allocate well, that we make good decisions about who in fact has the capacity to benefit from transplantation. And that concept of capacity to benefit is really, in my view as an ethicist, the key driver for situations of rationing in settings of pandemic. And I really feel that in a setting of a pandemic, we're not going to be able to do organ stewardship well unless we collectively share our knowledge and experience. That will give us the ability to really maximize benefits and minimize risks. Next slide, please. Now, I don't expect you to read the little light blue font on the left. It's just to show you that there are many, many pockets of data globally, data for transplant and donation. And in addition to those pockets or people that are collecting and controlling data, you've also got OPOs, you've got UNOS, you've got tissue banks, all sorts of hospitals, clinics, laboratories, institutes. You've got the air ambulance companies that are moving people around. And then there's a myriad of types of data that are all hugely potentially valuable. And this slide has an animation, so if you can hit next, the animation will pop up. There you go. I really want everybody to make friends with your data protection officer. You've all got one, whether you work at a university or a hospital or a research institute. This person, and you may have not met them yet, but they should become your friend like right away or yesterday. They will help you in your goal to share data and share it effectively and also share it safely. Next slide. All right, so now I know some of you are getting nervous already because you may work in an area or region of the world where you've got HIPAA or GDPR, and you know that if you violate, for example, GDPR, you will get a very, very big fine up to millions of euros. And you don't want that. You don't want to get into any trouble with the regulators. So I'm there, I understand that. But yeah, so the question becomes, well, what about consent? You know, do I have the proper consents to share data globally, internationally, across the EU into to areas which are under different regulatory regulations? Is it possible? Well, again, this data protection officer that you have, they will definitely have the answer to that question for your jurisdiction and also your IRB or your research ethics committee. These two groups are going to be great contacts for you. I assure you that 99% of you, no matter where you live, whether it's North America or Europe or Oceania, you likely already do have a provision for either emergency research and or public interest data sharing. All right, and again, it's your data protection officer as well as your IRB or ethics committee who can give you all the information on that. I've got 3 green bullets for you there just in case you're still nervous. There's two of those here are open access articles you can look to. They're very recent, just from the last couple months. And they talk about the laws and the regulations in various regions around the world in terms of data sharing in the public interest in terms of health crisis and things like that. There's also a contact person there of a guy who specializes in issues of data sharing platform development in terms of public interest. So I'll leave that for you there. Next slide. Also, I think it's very fair to acknowledge that some people are scared about data sharing. And yes, here's the big reasons. Number one, people say, but I've got IP, I've got intellectual property, I want to protect it. Or they might say, but my data could get stolen. It's very valuable, and I don't want someone to rip it off, you know, off the internet. Other people are worried their data will get manipulated. And then some people say, yeah, but I could even be accused of having fake data or data misconduct. I want to assure people that doing things via open access is not an open playing field for abuse for researchers. You can put in access limits. through access agreements and special contracts and terms of use that limit and set boundaries on how people get in to your area of a platform on the internet, for example, who gets in, how they get in, what they get to look at, and how they get to quote unquote use or play with your data. The issue of open access is very, very separate from the issue of data ownership. Okay, so depending upon your geographic region, you may still, in fact, have all your ownership rights to your data. You don't necessarily give those up just because you've gone and done open access. So I want to give you a little bit of comfort about that. And if somebody does come at you and make a malicious accusation that you've got fake data or bad data or whatever, that is actually a form of research misconduct, and those people can be prosecuted for that. So, and if you have data that is has some quality problems, that's something different, and maybe you need to look at those quality issues. But if you're really worried about somebody attacking you in an unfair way, that's a separate issue that can be addressed. Next slide. I want to benchmark with you just for a few brief moments. This is a site that has been active for quite some time. They initially focused on various types of influenza over the last several years. Now, as you can see on the right-hand side there, that map probably looks very familiar to you, where it says COVID-19 global cases. Every night on the news, you get an update, right, from Johns Hopkins. That's where it's coming from. They put their data here, open access for all the media, all the reporters, and all other researchers to get this data from. And it's going on this open access platform. And you can see here, this is from their terms of use. One of their FAQs, it says ownership is to remain unchanged. So if you decide—
just the one more slide, and then, because we are a little bit short on time.
All right, you can go to the next slide then. Next slide. Another option for you is Figshare. If you've got some transplant data related to COVID and you want to share it around the world so we can all get it, you can use Figshare. If you may already be using it through NIH, this is a great place to use it as well, and you still preserve your authorship and your licensing rights. So don't worry about it. Give Figshare a try. Next slide. Lastly is the journals. We want all our journals to be on board and get the COVID transplant related papers out there so everybody can see them. We've got 2 journals right now that have gone totally open access, the American Journal of Transplant and Progress in Transplantation. We've got some other journals that still need to kind of go fully on board with this, because there's some of them are still charging quite large APC fees, even if you're publishing regarding COVID. Next slide.
Okay, so we need to stop now. I think we need to open to the floor for questions, but I have just one question about the lockdown. How could we suggest to facilitate the restart in a sustainable and ethical way, Katrina? Can you tell us?
Yeah, I think lockdown has to be driven by medicine. It can't be driven by politicians or economists. There's this saying right now on the internet, it's called "Don't die for the Dow." We can't put it in the hands of people who don't know about medicine and epidemiology and ethics to be making the decisions about lessening the lockdowns, or the other thing is we have to be looking for spikes, because I know when we do the lessening of the lockdowns that we have and people start interacting more and going out and this and that, we are going to see a spike. We saw that with the Spanish flu. And we need to be prepared for that as well.
Thank you very much. So now I'd like to first thank all of our panelists for having given so high valuable insight into the main issues. I would like to invite the floor to raise your hand button on the dashboard to be unmuted and submit your question, or you can also type the question in the chat window.
Okay, it's Luca Segantini here again. I'm monitoring raised hands and submitted questions. So I see there is a question from Dr. Kalogeropoulou, and I'm going to unmute her so she can ask her question. Please go ahead and pick up. Dr. Kalogeropoulos, we can hear you now and you can ask your question. Hello? No. Then I'm going to move to Dr. Shakali, and I'm going to unmute him so he can ask his question. No. Okay. Then I'm going to read some of the questions that have been submitted on the chat window. Okay. And there's one question from Dr. Leventhal. What drugs are you treating patients with at home? I don't know who wants to answer this.
One of our panelists, Professor Nicholson? Okay.
I might give a quick answer to that, suggesting that it's very variable. And I know that hydroxychloroquine and azathioprine has been used in Italy and in Spain. We do not provide any care for patients at home in the United Kingdom. I know the topic has been challenging in France. So because of the small evidence and because of the, as Katrin said at the end, because the politicians are driving more of the choices than physicians and clinical people, then there's a huge variability across countries. I have a question too. I don't know whether I can ask it.
I think so.
Go ahead.
I'm very curious because I talk often about this, even with Irene. I believe that transplant represents the problem quite well. Can you estimate the size, the proportion of the indirect death caused by COVID-19 in terms of patients needing surgery and delaying surgery or needing intensive care beds and not be admitted to intensive care? Do you have an idea how big is the impact on the normal population?
I would like to ask David Paredes about this, because we previously had a conversation offline about the fact that, for example, in Spain, the numbers of DBD is lowering down. Do you think there is a connection because people actually do not go out and don't have car accidents? Don't know.
Well, this is a very interesting and a nice question, because we are confronting a decrease in the number of people with severe brain injury or severe cardiac damage arriving to the big hospitals where it can be evaluated as a possible donor. So we don't have exact data, but we don't receive anymore any uncontrolled DCD to any hospitals in Spain, for example. So probably all those cases are dying at home, or are dying in at the medical residence, or are dying in little hospitals, and we are not transfer these severe cases to the hospital. So these deaths that probably are caused not by the COVID infection, by other causes, will be in some way hidden by the numbers of the COVID. We are now starting to make this calculation in the quality control program with the ONT, and maybe we can show you some results about that, especially in those big topics.
Okay, but also, if I may add something, Irene, just quickly, it's not people not going out. You don't have ITU beds. The ITU beds are all taken for COVID patients. So that's the main problem. And the other thing is, it's not just, it won't be much in terms of kidney transplant, but it'll be mainly the life-saving procedures. So kidney, liver transplants, lung transplants, heart transplants, and also complex surgery, HPB and cardiac surgery that needs ITU beds. All these together will have a lot of produce a lot of indirect deaths. Thank you.
So, Professor Cillo, do we have at an Italian level a way to monitor if there is an increasing waiting list mortality COVID related?
That's a very, very relevant question, actually. I've been asking that to the National Center for Transplantation a couple of days ago, And as far as they look at the data so far, they didn't find any increased mortality in the waiting list. But that is because it's too early. So the crucial factor is time, how long this will prolong in time in terms of ICU bed engaged by the COVID, and this will transfer in terms of waiting list and oncologic waiting list mortality, because we don't need to forget, again, as Paolo was saying, the oncologic waiting list mortality. I think that another factor will be how we'll be able to manage the phase of getting out from the peak phase. If the ICU in Italy are more free recently, we are getting more free ICU beds, and we are opening a little bit, but we are pretty much scared about rebounds of the infection. This will be critical in terms of prolonged death.
Okay, I would like now to open again to the floor. I guess there will be more questions coming. Luca?
Yes, I have one raised hand from Dr. Fernanda Ortiz, who is now unmuted. And if she clicks, okay, maybe you can try asking a question.
Yes, can you hear me?
Yes.
Yeah, hello, Fernanda, welcome.
Okay, hello, Irene, nice to see you. So thank you for this great opportunity. So my question is more ethical. I wrote it down even in the chat box. Is that we have, as most centers, stopped the living donation program. And we have already 20 couples just waiting for this living donor transplantation. And we know that all these surgeries are accumulating into the fall, maybe, or next year. So we are just punishing those living donor candidates. And we are still continuing our disease program. So we are giving the chance to those waiting for a diseased kidney, and we are just keeping this opportunity off from those patients who are waiting, although they do have a living donor. So should we put just for some time all these candidates in the waiting list? What do you think? Because we just have a talk today in our hospital in Helsinki, and we could not figure it out. What will be the most ethical, and what is the right thing to do? Because they will be waiting maybe for 1 year until we can just solve all this, not only the transplant surgeries, but any kind of surgeries have been delayed. So there will be problems in the fall. So what do you think about that?
Katrina, would you like to answer this ethical question?
Yeah, I think I can answer a piece of it. I know at the hospital that I work for, we are still continuing to screen and assess living donor candidates through telemedicine, because we want to still keep the pipeline sort of moving rather than just crush it and stop it totally, because we feel that there is benefit to still screening these people who are coming forward and offering themselves to be living donors rather than just grinding everything to a halt. So we are still very actively doing that.
Time for another question. Thanks, Katrina, and thanks, Fernanda.
Yes, I have a question from Dr. Dale. Is there an agreement on definition of COVID death? It seems like Germany did not count as COVID death if the patient, in addition, has pneumococcus. Maybe a question for Dr. Nadalin.
Yeah. Silvio, would you like to answer?
Yes, could you repeat just shortly the question again? Sorry.
Yeah, Luca.
He asked about a definition of COVID death in Germany, because it seems like in Germany you're not counting if the patient, in addition, had pneumococcus. Maybe you can clarify that.
Yes. So okay, you're right. So they are really death because of. So the primary cause of death is pneumonia and the multi-organ failure due primarily to COVID. It's not, for example, a patient who died because of some other reasons. Let's change completely scenario. Complication after heart attack, heart infarction, and on top of that, COVID infection. So primary referral is COVID, and cause of death is COVID. This is probably one of the main reasons, my personal opinion, that the different, because in Italy they test everybody, every people who died, and they find the COVID. Oh, this was died because of COVID. I don't know. What do you think, Umberto?
I think that in this phase, we need to have overall number, and then we are going to stratify in a later phase. But now we need to know how many people died while we're infected, because to put a definition is too difficult and too subjective. So we need to have the overall incorporated data in order to do ex post analysis, actually.
This is very important. I want to underline how important it is to have a clear data, because even in the United Kingdom, if we had not confirmed testing, we will not report the suspected death as related to COVID, and that makes really confusing results in the overall population. If you don't test and if you don't put the same cause of death across all countries, the mortality overall will come across being very different, whilst probably it is not.
If
so
I
would like to invite all of our attendees to post their questions offline on our forum on Transplant Live that is dedicated to COVID-19. There will be a discussion topic that will be just dedicated to this webinar that will be put just immediately after we finish. And so they could go through, and if they have any question, the question will be posted, and then we'll make sure that this will be also answered. Now, for time reason, we need to move, unfortunately, to the conclusions. Francesco, if you want to give a brief insight.
Yeah, so I will give you, as promised, a very short provisional information about our surgery. The first slides, I will be very quick, is basically how we plan to do the surgery in two main topics, which are the demographic and the survey domains. In the demographic, what we really are interested to know is the position. So if people are surgeon, ICU, ethicist, or other type of figures, and what's the transplant interest. And we did this through different sources, making a web-based survey on Castor platform. The survey domains are 5, and they reflect many of the questions and the points that we have discussed during this webinar. The transplant policy, how do we deal with the deceased donor or living donor, the ICU resource distribution, and what we want to know is even how we should screen people, not only transplant candidates, but also the healthcare workers. And finally, we are interested in the equity of the distribution and what's the consent policy in consenting people for an extra risk. So please, next slide. Next slide. So now we have 1,600 people answering to the survey in 79 countries. Could you click again? Click again and again. And as we expect, we have lots of people in Europe, almost 800 people, and where we zoom in the answer, we see that most of the people that are answering are working in a high volume hospital. Next, please. They are head of the team as definition, and next, please. They are well balanced between transplant surgeon, ICU referring doctors, and we have a small but significant part of ethicists on board. Therefore, we are still ongoing. We hope to reach much more answer to give a figure of what's our opinion, and finally come with the publication that will give the community some benefit in terms of recommendation. Next, please. Thank you very much.
Thank you very much, Francesco. We are looking forward to see the results of the survey that we are going to share on Transplant Live, aside with this webinar and the discussion topics that will be posted straight away. Before leaving you and thanking you for being with us until now, I'd like to ask you what was the impression of your webinar. If you can please vote with a poll.
The poll will come up in a moment. It's just one question.
We can see it now. Okay, thank you so much, and see you to the next webinar and on Transplant Live. It's free, you can register. Thanks.
Thank you very much. Bye.
Thanks a lot.
This video is part of Transplant Live, an e-learning platform from ESOT. Please take the time to have a look at the other content available.